Welcome to the Checkup. I'm Aurora Aguilar, editor of Modern Healthcare. Over the years, I've spoken with many hospital leaders about how their facilities affect the economies in the areas they serve. Hospitals are vital infrastructure and often are large employers, which means the decisions they make for their own operations send ripples across the communities they call home. Their status as big businesses and essential healthcare providers also makes them highly influential in local affairs. Inequality is endemic in American healthcare, a fact the establishment increasingly is accepting and vowing to resolve. Achieving health equity is imperative to the system's mission to promote good health and wellness in every part of every community, and pressure has intensified over the years to deliver on longstanding promises and demonstrate real results. That's why I was drawn to a recent LinkedIn post from Dr. Shereef Elnahal, the president and CEO of University Hospitals in Newark, New Jersey. Dr. Elnahal shared a series of infographics elegantly illustrating the meanings of the terms equality, equity, inequality, and justice. Those are key concepts that are often misunderstood. Dr. Elnahal joins us now to talk about how he uses these visual aids to explain University Hospital's anti-racism and health justice agenda. Welcome to the Checkup, Dr. Elnahal.
Thank you so much for having me, Aurora, and thanks to Modern Healthcare for hosting this important discussion.
Of course, thank you for joining us. So tell us how these images reflect your philosophy and how they shed light on what you're doing at University Hospital.
Yeah, thank you. And it's really important to us, Aurora, for a lot of reasons. The first reason is that actually our history as a hospital very much embedded into the issue of health equity because our hospital, as did many major institutional structures throughout the history of this country, actually displaced one of the most prosperous Black communities in the country about a century ago. And so the tension with the very community that the hospital is supposed to serve was really maximized from the beginning. And then, of course, the civil rights movement in the 1960s took many forms across the country. Some forms, of course, were in the form of uprisings. And in Newark, there was a rebellion from the community here because precisely because the government did not meet the needs everybody in the community equitably. And so our hospital was a major subject of the agreements that actually ended the uprisings in Newark, and those agreements were codified in the Newark Accords, which I keep on my desk and review every morning. In front of me every morning so that I can be reminded why I am here. And those agreements rededicated us to the community. And so it's important to really break down these concepts because you can't really address them or operationalize how you address them until you understand them. And when I mean you, I mean the leadership all the way down to the front line in our organization. And so the first is the baseline state, which is simply inequity. It is the baseline, unfortunately, for healthcare outcomes across this country because opportunities have not been made equal to folks based on their zip code, based on their socioeconomic status. And that's why you see the disparity in the outcomes that you see across the country in healthcare, chronic conditions, susceptibility to infectious diseases like COVID-19, the fact that COVID-19 was the number one cause of death for people of color in this country in 2020, number three cause of death for the general population. And so that presents the baseline problem to solve. So one approach has been one around equality, which is to provide universal benefits to everybody in society to give everybody a hand up. And of course, if you have groups of folks that start at a much lower baseline, those benefits don't end up being enough. And so a classic example is Medicare. Medicare is a universal benefit for everybody over the age of 65, but does not necessarily solve for the inequities that people of color have faced in this country for so long and often isn't enough, especially for our dual eligible patients and patients who were born into and continue to live in poverty. Then the next level up to that is an approach toward equity, which is to essentially, in a patchwork way, solve for the fact that marginalized groups of people don't have equal access to opportunity. And so our hospital programs that fall into this category include our hospital-based violence intervention program for vulnerable folks who've been victims of or even perpetrated violence in the community. Our trauma center treats them, but then we provide wraparound services to prevent violence from happening in the future and convince folks that there's an opportunity to thrive. And those are resources that we are dedicating and have grant money from the state to do so, to make sure that we're providing a hand up, mostly to people of color and people of lower socioeconomic status, so that they can have an opportunity to thrive and become healthy. But ultimately, the real goal is justice. And justice involves correcting the systemic inequities at their root, at the core. And the key to that, bar none, is economic development, to allow for everybody to have an opportunity to participate in the economy, to have a career path, a career trajectory. And you can do as much as you want with targeted benefits and programs, but unless you are fixing the system to better allow for economic thriving of everybody in the community, you're not going to do that. And as an anchor, as a major institution in this city, we have a big role in that. We are among the biggest employers in the city. We are going through multiple initiatives to hire locally and hire more people from Newark in the community we serve. We're among the biggest contributors to the mayor's Hired Newark initiative here. And we are also making strides in procuring more from local small businesses and minority and women-owned businesses as well. And finally, we are building a new hospital on this campus, and I'm very excited about that. We have to do that in an inclusive development way, so that we have organic, locally formed small businesses and contractors supporting that work, so that more people can be employed, wages go up, and more people have the opportunity to thrive.
So, one of the things that we've been keeping track of every month in our publication has been the goals and also the money allocated towards some of these initiatives in order to really sort of see exactly how much of dedication and how much sort of impact potentially those programs can make. So, talk a little bit about some of the measurable results that all that you've talked about so far have had on your employees and then also in your community.
Absolutely. I'll talk about two of our programs as an example. So we, again, have this hospital-based violence intervention program. The number of referrals that we've been able to make to social services in the community, the number of housing referrals for folks who are homeless and were victims of violence have skyrocketed since the beginning of the program. And very importantly, we've seen a reduction in overall emergency room utilization with the combination of our hospital-based violence intervention program and our trauma survivorship program, where we really escalate the level of care and services we're providing in the community, in our clinics, and at home in many cases to prevent the need for emergency care, because we're addressing issues before that has to happen. In terms of our Familiar Faces program, that's a program where we address the folks who come to our emergency room over and over again, largely because of a lack of social supports at home and a lack of a home in the first place. We've been able to also escalate community health worker intervention and engagement with patients in the community. And a major marker of success there is not only improvement in some of the preventative health measures like cancer screening and screening for hypertension and other chronic conditions, but again, reducing the need for emergency room utilization over time. I think it's important, though, to mention that really to achieve health justice in this country, we need the gears of policy behind us. We need the inequities, for example, on reimbursement of things like mental and behavioral health care and addiction care to be right-sized, because these are conditions that really reduce quality adjusted life years and cause death far more than is appreciated. And the value in terms of the quality adjusted life years that you are offering to people by getting them off of their opioid addiction with medication assisted treatment, that value is not reflected in the reimbursement that providers see, especially against things like procedures where you may be adding quality of life and you may be extending life to an extent, but in many cases not nearly as much as providing that basic preventative mental, primary, and behavioral health care to the community. And so that's just one example of many things that the federal and state and local governments can be doing to achieve health justice.
You talked about economic equity, and we all know about the impact that the pandemic had on communities of color as far as fatalities and case numbers. But it also had a disproportionate impact economically. So 61% of Latinos and 44% of Black Americans say that they or someone in their household experienced job losses due to the outbreak, compared to 38% of white white Americans. So, thinking again about the messages those illustrations send, how can hospitals work with public and private sectors and in policy issues, like you mentioned, to attack the underlying causes of these inequities?
Well, one of the major reasons, Aurora, that you saw that trend is that our essential workforce is disproportionately composed of people of color, Black, Latino, and other underrepresented minorities by far outpace white and some of the majority groups we have in this country. And so, of course, they were more exposed to COVID-19. Of course, they have more difficulty achieving access to care and preventative care in particular. So, at baseline, their chronic conditions were worse, and there's just a higher prevalence of chronic conditions. And so, that's a major reason we saw that trend. And so, when it comes to economic development and economic opportunity, I think every organization, especially in vulnerable communities, needs to be thinking about not only how we recruit talented people of color from outside the community and outside the organization. We have Ivy League institutions that are offering, graduates who are people of color who can fill any job, extremely well across the country, but actually making the investments to develop careers locally. So we want our entry level folks in University Hospital getting apprenticeships, getting trained so that they are the most qualified candidates for promotions and they're entering the supervisor, the managerial, and eventually executive level from the ground up. And I think that is really what we mean when we talk about justice in the community economically, because unless we are offering economic mobility, folks who start out because of, again, where they live, what they inherited when they were born, but then with opportunities and investment in pipeline growth, we want to bring more people up the socioeconomic chain right here in our community and really be able to face the community and say, we are developing folks and we are contributing to the economic thriving of the community. So I think every organization can do that. It requires investment. It requires making it a clear priority because it's not cheap. It costs money, but it's well worth it because the trust that you get and the talented people that you can foster in a system like that is really amazing. And we've made a lot of those investments here at University Hospital.
In just what, almost 3 years that you've been there, close to? So a very short while.
Yeah, just over 2 years. So it's felt like a lot longer than that because of the pandemic, of course. But I just can't tell you how proud I am of the team here. It's just an incredible group of people. And so every day is just made easier by the mission oriented folks that we have, largely from the community, serving this community.
So, to get beyond the rhetoric that you normally hear about social justice, and since you are seeing results, give 5 proven strategies that you think would help other hospital leaders be able to really get beyond this rhetoric.
Yeah, it's really important to get to substantive work here because I think the health equity academic community has done a great job of characterizing the problems. But what we don't have yet is the full slate of solutions on actually how to address these inequities. And so we've done a number of things at University Hospital that I can offer as a framework. The first is to set the agenda as a priority in your institution. So every organization has a mission and values. If you're not setting, health equity as a major priority and a major value in your strategic plan, it's not going to be reflected in what your direct reports and every leader in the organization is going to be focusing on. So setting it as a priority, making it clear is important. And part of that agenda is to also set timelines and metrics for improvement as part of people's performance framework. So we have health equity as its own category of performance metrics for every leader in the organization, myself included. These are not easy metrics to achieve, and they shouldn't be. They shouldn't be only process based, where you sort of have these forums. I mean, forums and safe spaces and discussions are important, but unless you're actually devoting the time and effort and making progress, you're not going to achieve that. So setting the priority and setting metrics and timelines and performance standards is very important. The second is to recruit a team behind those priorities. So the health equity task force that we have is very thoughtful. We have folks from across the organization, people of color, people of different LGBTQ identities and gender, but also folks who may belong to none of these communities, but are allies who are involved. And to have that representative group is important because they then set the specific initiatives and set the metrics for everybody to follow accordingly. The third is to take a serious approach to implicit bias. So implicit bias is a phenomenon where you have clinicians who are not aware of their biases, providing care and providing inequitable care because they replace assumptions about patients unwittingly, in most cases, with facts. So they're assuming that you're in here for a certain reason, or you have a baseline condition that you may not have. And so, of course, care is derailed and care is suboptimal as a result. So the implicit association test is a great tool. We've had our clinicians take that on a pretty large scale here, but then it's important to follow that with supportive structures to make sure that people are supported, because it's never a good thing for a clinician to hear that they have biases, but the reality is everybody has biases. And unless you're addressing that issue head on and provide that support structure for your employees, you're not going to address it. And then over time, the way you measure that is the IAT should get better over time and clinical care should improve. The fourth is focusing on ourselves as an anchor, and that's really going to characterize the fourth and fifth priorities here. So major role of an anchor is to actually source more and more of what you buy from the community. And so that requires your procurement departments to get with the program and stratify what you're doing by local, women, minority, and veteran-owned businesses for that data to be transparent, and to propose plans every single year to get better and better at sourcing from the community. You would be surprised how much quality products are available right next to you. And of course, you have to pay a little more sometimes, but the idea is also to help those businesses provide better offerings over time and connect them to group purchasing organizations and some of the established structures, so that it'll just be easier and easier to procure from these folks as we move forward. And then the fifth, of course, is pipeline and workforce development. And so I mentioned some of the things we're doing at University Hospital, but if you are part of the effort in broader city, broader county, broader state efforts to create extremely talented workforce where you have people of color, you have LGBTQ representation, you will be successful in filling the ranks of your hospital with talented people of color. And a lot of things will fall in place when you do that, because the trust that you'll establish, not only with your own workforce at the front line, but with the community, is extremely important. And so those are just some of the things that underlie our framework and our task force's work in this area.
Well, thank you so much, Dr. Shereef Elnahal, the President and CEO of University Hospitals. Thank you for joining us on the Checkup today.
Thank you.